Now, we'll ask you to present the talk on percutaneous valve implantation for pure aortic regurg. This talk's supposed to be given yesterday, but because of his flight arrival, we postponed it till today, and the committee felt this is a very nice topic to be presented. So thank you very much for coming and presenting this talk.
And thank you very much for enabling this talk, because it's close to my heart. It's really something that we've only started this year and is really worth communicating because it's new. So the talk will be, look a little bit at AR, because we know everything about aortic stenosis, but not so much about AR. TAVI with contemporary valves, and then the inner valve trilogy, concept and implantation, and results. So primarily it's a degenerative disease of the cusps, but it can also be caused by aortic root problems or abnormalities of the ascending aorta. It's not only just the valve. And infective endocarditis. And I've just heard this morning that in this region also rheumatic heart disease can play a role in the degeneration. But the most common cause really is tricuspid or bicuspid degeneration, 2/3 of the cases registered. The echo criteria for severe AR are qualitative, semi-quantitative, and quantitative. I'm not going into them, but on the left-hand side they're measured. Important is to assess the aorta on 4 levels, and if not clear, use a CMR and to help. Indications for surgery according to our European guidelines are 1B in symptomatic patients regardless of LV function. If they get breathless and aortic regurgitation is the only problem, then you get surgery. Asymptomatic patients with an end systolic diameter of over 50, or according to body surface area, more than 25 millimeters per square meter. And then a 2BC surgery may be considered in asymptomatic patients with larger ventricles, and then surgery, a 1C surgery is recommended in symptomatic and asymptomatic patients if they undergo CABG, so you don't leave an aortic regurgitant valve alone if patients have bypass surgery. And then on the bottom, there we go. Repair may be considered as a 2B, so not a bit lukewarm. So also, of course, if you see a patient many times and the end diastolic diameter goes up, or if their LV function starts to deteriorate, and then over 65, you should probably do something. So this is the usual path to AVR. On the left-hand side, you have got some criteria, and then put them up for surgery. On the right-hand side, there is not really a lot of data on survival and the effect of surgery. So this is what we believe happens. That's a matched population on the right-hand side, showing that patients with surgery do better than those without. There's one really good paper out there by Turani. The senior author is Martin and Sushil Kodali, and they looked at treatment patterns, disparity, and management strategy in a US database of 4,608 patients with severe symptomatic AR in the years 08 to 16. They found 9% mortality at 1 year in patients that received surgery, and 24% if patients left untreated. So that's a 2.7-fold increase. And only 26% of patients with severe AR and symptoms had a replacement within a year. And on the right-hand side, you see the subgroups and the effect of surgery over medical treatment. And if you look at factors that impact the treatment decision, i.e. which patients don't get surgery, it's the usual suspects, women, elderly patients, and patients with reduced LV function, the ones that also cause the higher risk in surgery. So they're just simply not treated. And that used to be the norm. And of course, now comes TAVI, and the question is, why don't we treat them with our TAVI systems? Now, if you look at the valves, on the left-hand side, the very familiar picture of calcific aortic valve stenosis, on the right-hand side, a regurgitant valve. And our problems here, of course, there is no anchoring. There is no calcium there to keep the valve in place. And believe it or not, our valves rely on that. The self-expanding and the balloon expandable valve, they need calcium there so that they don't fly away. Because if there is no anchoring, there's embolization, there's migration, there's also less sealing and more residual AR. So this is what happens. Nice Italian paper here from which I stole the illustration. Migration, leakage, and the use of additional valve. And what is our strategy? We just put in bigger valves. We oversize. So this is what happens. On the left-hand side, the attempt to put a core valve in a leaking valve in a critically ill patient. And you see the movement. I'll play it again. Core valve seems to be in place. And now it's a bit low. And before long, you find yourself at the end of a snare and trying to pull up the valve into a correct position. Do we have data? Yeah, we have data particularly for the first generation valves, and these are 4 papers, exemplary, increased mortality at 30 days in these patients, more than moderate aortic regurgitation, up to 23% in these series, and dislocation or a second valve, again, over 10%. You would really think this is unacceptable, but that's what happens. There is a registry, Pantheon, I alert you to that, that will next present at PCR London Valves, so in 2 weeks' time, and they collect all patients with native aortic regurgitation treated by TAVI. So, here is one of my patients, Mr. P, 82 years, increasing shortness of breath, severe aortic regurgitation, and some colleagues of mine, including proctors for the Medtronic core valve, tried this. That was a year ago. That was the first attempt, and you can see that didn't quite work. That was the second attempt. That didn't work either. And that was the third attempt, and another one. And what they did now, what we did now, was we just removed the whole system and closed the groin and aborted the procedure because there was no option despite an oversized system in his aortic annulus, and we just gave up. And he was waiting. Now, the new thing, of course, is the Trilogy valve, which is a dedicated system for AR that has CE mark for treatment of aortic regurgitation. It's a self-expanding frame, and it has a sealing ring down here, which is important because this is slightly oversized against the annulus or outflow tract. And it has, as very unique features, these locators that will be positioned in the 3 cusps of the aortic valve. And the sealing, the anchoring, works by clipping the leaflets between these locators and the expanding valve, but also because the outflow tract part of the valve is slightly oversized. So they can't go south and they can't go north. In addition, more or less free of charge, comes 100% commissural alignment by definition, and because there are big holes where the coronaries come off, free access to the coronaries afterwards. German experience, 45 patients, has been presented at Euro, PCR, and all cases performed transfemorally, 80% under conscious sedation. Post-dilatation was necessary in 2 cases. Procedure time 77 minutes. It can be involved to place the valve in the right place. The system I have described Technical success there, 100%. Mortality 0. The mean gradient afterwards 4, and the aortic valve area at discharge 2.6. It's big. New pacemaker 23%. That's the catch. 91% none or trace AR, and 9% mild. No case of severe aortic regurgitation. It comes in 3 sizes with these parts. The real crucial bit about the implantation is to make sure that make sure that the locators are all definitely in the right cusps. So you have to use a bit of imagination and sometimes a multi-purpose catheter to get there and selectively inject. So back to Mr. P. He came back for a trilogy implantation, and this is the implantation. You can turn the system to orient it and make sure that you're in the right place. You then advance it like so, and then you confirm the position. We did that, this was an early series, we did that with an injection with the pigtail catheter that can interfere with the locator, so it's recommended to do an MPA, but we did it here with pigtail injections, just making sure that we have all the locators in the 3 cusps. Then we have to confirm the depth. You see the ring there is underneath the annulus, so we're happy. And then the deployment is really scary because it's a split second. I'll show you. Poof. And then it's in place. You remove the system without pulling out the valve, and this is the final result in this case, and on echo. And I can tell you at Barts and Cleveland Clinic, we've done 11 so far. Doesn't sound much, but it's a large series compared. Technical success 100%, 1 small hematoma, trace or no PVL. We didn't have really a problem with that. New left bundle branch plug in 3 and permanent pacemaker in 2. We're 20% pacemaker rate. Improved symptoms, most of the patients with, apart from 1 patient with severe lung problems. So, sounds good, but is there evidence? There is a trial in the US that has just completed enrollment, the IDE trial. We'll expect results of that one next year. So that's required. Long-term durability, we don't know, of course, that has to be said, but there's no reason to believe it would be different from the transapical version, which was very good. And, you know, when should we treat patients with AR? We really don't know. And in the end, of course, somebody will come up with the idea that TAVI might actually be better than surgical AVR, even in these patients. So in summary, percutaneous valve implantation for pure non-calcific AR remains challenging. There is a dedicated novel valve system, and that may provide a solution. And lots of gaps in evidence need to be closed. On that note, thank you very much for your attention.
So thank you very much. So trilogy valve is a game changer, Ahmed. What do you think? Or Hani?
Thank you very much, Dr. Baumbach. That was amazing. When I work in a country where we have a lot of rheumatic AR, and some of those patients come and they're really myopathic, but they have little symptoms because it's like a high cardiac output failure. But when we get the aortic valves replaced, you know, the mortality is very low because they're young, but many of them spend a stormy post-operative course in the CCU, you know, till they get off support. Do we get any patients after correction of the severe AR with the prosthesis going into any significant left ventricular worsening of the left ventricular dysfunction? Because that would be a huge plus over surgery if they just go home 2 days later.
Yeah. Well, you know, we've selected patients that walk into the hospital and walk out, and there wasn't any problem post-operatively. It's just like TAVI. There is something happening in Germany. I haven't done a case, but in Elvat there is the occurrence of aortic regurgitation, and the valve has been used in these patients. They are obviously critically ill, and I'm told with good results. I've yet to see a series being presented, but that's practice already in Germany, and in these critically ill patients it does well as well.
That's great. Thank you.
Andrea, it's a great case. You said in one of your cases, our indication maybe in our region is rheumatic, which is, we face a lot of rheumatic heart disease, particularly in aortic root dilatation. Do you think that the pathology, the valve itself and aortic annulus will not compete with the Jena valve? I mean, because you have 11 cases, you have a thesis. I know that you don't have the right answer, but in your explanation, because you have already 11 cases and you have tips and tricks in doing this. If you have a pathology of the rheumatic heart disease or the valve, and also if you have an aortic aneurysm, if you have you can put a stent in the aorta as well?
I'm not sure I understood completely. What I can say is that in very enlarged annuli, this valve is not, there is no model over 30, so we had to turn down some patients, particularly young patients with large annulus pathology. An ectatic aorta wouldn't be a contraindication in the first place. You don't need the aorta to anchor or to stabilize or anything like that. To combine things with a stent, yeah, that's always, it's sort of the holy grail to percutaneously fix the whole structure from annulus up to the arch.
And the first part is rheumatic. Do you hear me?
No.
Rheumatic,
yeah. We don't have experience with rheumatic aortic regurgitation at all, I'm afraid.
For the valve, it sounds promising. Just a question about the clipping. Is there any, when you're evaluating these patients for the procedure, is there any special anatomy that you're looking for, or does it work for?
Yes, they are very good question, and I should have mentioned that. I need to put that slide in. We do have exclusions that have to do with the angle of the aorta coming into the left ventricle. I just had one through email this morning, disappointing, and the size of the annulus as well. Not much else, really. But the angle is a problem because of the approach and the delivery of the system.
So you think it's going to be easy to generalize it as to having a lot of excluded patients just because of the anatomy?
Yeah, I can tell you from, we've screened 20, well, we've screened 20 and now accepted 14, so it's that ratio, right?
Andreas, one quick question. So the 11 patients were all native aortic valves, right?
Sorry?
The 11 patients in your series were all native aortic valves.
All native aortic valves and all pure aortic regurgitation.
Any experience with degenerated roots, so degenerated freestyle roots? Because those are a nightmare to treat.
There's one case report with the inner valve in the literature where they did a root replacement, and yeah, anything, it's what you don't want. It would also be good, you would have thought, for valve in valve, but it hasn't been done. The anxiety is always that the locators interfere with something and get entangled, right? But there is one, at least, report in the literature about a root replacement that's been treated with the inner valve with very good success. Anything you can safely put those 3 locators into 3 cusps will do.
Good.
Yeah.
Thank you.
Thank you very much, Dr. Baumbach, for joining us the first time in GES. Thank you for your contribution and your presentation. Thank you very much.